Maltesh will start off.
Okay, sir. So, good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a station assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by Indian Association of Preventive and Social Medicine, and the topic of today's session is HIV Sentinel Surveillance. So let's begin today's session, for which I would like to hand over this session to Dr. Animesh Jain, sir. Over to you, sir. Please proceed with your talk.
Thank you, Rupsa. I just want to make a correction. IAPSM Karnataka chapter, because we have IAPSM National and then various state chapters. So this is IAPSM Karnataka chapter. So please make a note and henceforth, please use that as the address when you say.
We
Thank you.
apologize for this, sir. Actually, we were provided this information. Sorry for the
Yeah,
inconvenience,
no,
sir.
no,
You may
it's there in
continue.
your banner also, IAPSM Karnataka chapter. Right. Okay. So yeah, good evening, everyone, and welcome to this another session of IAPP, that is Intercollegiate Academic Program for Postgraduate, where we bring webinar almost every month, and we bring out topics which are of interest for mainly postgraduates, but also faculty members and anybody who's interested in public health and alike. And this is another edition. I'm very happy to have Dr. Maltesh with me today on the topic that is HIV Sentinel Surveillance. I have known Dr. Maltesh for probably a decade or more, and it's a pleasure that I have the honor of introducing him and also moderating this session. So let me do the job quickly and hand it over to him. Before I do that, uh, I want to tell about Maltesh. So Dr. Maltesh Undi is working as assistant professor in epidemiology, or rather as an epidemiologist in the Department of Community Medicine at the Karwar Institute of Medical Sciences at Karwar in Karnataka. He's also been an esteemed member of the state surveillance team for HIV Sentinel Surveillance for a decade now, 2014 onwards till now. And in his capacity, he's been also involved in training uh, various professionals in the surveillance related activities and surveillance teams he has trained, which constitutes of obstetricians and gynecologists, medical officers, project managers, lab technicians, counselors, prison sites, HRG sites, you name it and you have it, under the aegis of KSAPs as well as ICMR NIH Chennai. So he's been working in the capacity building area, and he has also been monitoring and supervising the implementation of this HIV Sentinel surveillance in the HSS plus Sentinel sites located in the various districts of Karnataka state, traveling very often and to far places, 2,500 kilometers during the period of year in 1 year. He's been trained formally in HIV Sentinel surveillance, and he's undergone this training under ICMR NIE, that is National Institute of Epidemiology at Chennai, and also under NACO India. Other than that, he's also an evaluator for various national programs like NACP, NTEP, NVBDCP, as well as RMNCH plus A. He's been working as WHO external monitor for the polio program and intensified mission Indradhanush program 5.0 as well. He's been the nodal officer for sub-national certification of TB-free status under NTEP Uttar Kannada state, district in Karnataka, India. And he's also been a nodal officer for COVID-19 home isolation telemonitoring of Uttar Kannada district in Karnataka. Just to give you an educational background, I could say that Dr. Maltesh has always been pursuing his quest and thirst for knowledge. So after completing his MBBS from WIMS Ballari in 2010, he went on to pursue his MD in community medicine from KIMS Bengaluru in 2014. He didn't stop there. So though he was working in Kawar as assistant professor, but he in 2016 from PhD Coimbatore, and that's under Bharatiya University in Tamil Nadu. He also went on to do his advanced course in medical education from NMC Nodal Center in JNMC Belgavi in 2017. Followed it up with a FAMER fellowship where I again interacted closely with him, and he completed his fellowship with distinction in 2019. Presently, he is also one of my colleague and a GC member at the national level of IAPSM. He and I represent the southern part of India in the IAPSM National GC. He's also been the convener of Academia IAPSM eConnect, which is a very vibrant and and a platform where they bring in a lot of good programs online. He's also been awarded IAPSM Special Presidential Appreciation Award for Faculty in 2023, IAPSM Presidential Appreciation Award for Faculty in 2022 from National IAPSM. He also received Best Outgoing Student Award from Bharatiya University, Tamil Nadu for his PG Diploma in Bioethics in 2016. And he's been RGHS, that is Rajiv Gandhi University of Health Sciences University rank holder in MD Community Medicine exam. An active researcher, he's got more than 35 publications. He's been an editorial board member for a couple of journals, received Best Oral Paper and Poster Presentation Awards, and needless to say that he guides lots of students for various research projects, including ICMR, STS, and RGHS UG grants. He's also authored chapters in books like IAPSM Textbook of Community Medicine and IAPSM Research Methodology. So in brief, this is my pleasure to introduce my friend. I think he's an inspiration for many, and at this young age, he's done a lot of things. So with that, over to you, Maltesh. Looking forward.
Thank you, sir. Shall I start, sir?
Yes, please. Go on.
Thanks to Dr. Animesh sir for introducing me, and also a good support and inspiration to me, where it has motivated to me to work as well as acknowledge wherever it is needed. I thank all the office bearers of Karnataka chapter of IAPSM for providing me an opportunity to interact with postgraduate and youngsters in one of the field where I am actively participating since almost the last decade, that is HIV Sentinel Surveillance. So I like to acknowledge NACO New Delhi, ICMR National Institute of Epidemiology Chennai, as well as CASAPS Bengaluru for having provided me immense knowledge and opportunity to undergo training, train others, monitor and supervise various HSS implementing sites, and also the reports which it has made available in the public domain, as well as various materials, including some of the slide content might have been taken from some of my TOT, which is again a propriety of the ICMR NIE, and I am using it with due credits to these institutions. However, I would like to give a disclaimer that whatever I express, the views and opinions are mine and do not represent any of these institutions' positions, as well as the institute where I am working. So with this disclaimer, I would like to continue. By the end of this session, I think the participants should be able to explain what a surveillance is and also what HIV Sentinel Surveillance is. Moving on, they should be able to understand the roles and responsibilities of the personnel involved in surveillance. Sometimes we read HIV Sentinel Surveillance from various textbooks or reports or operational manuals, but having worked in the field, it's my pleasure to explain how actually these people work at their own places, which in turn gives rise to so many important data based upon which the national program runs in our country. They should be also able to list out the eligibility criteria for all the three, that is antenatal women or ANC sites, prison sites, and HRG surveillance. They should be able to describe the methodology, which I am going to explain in detail, because I thought that let my field experience make them understand the methodology of HSS better, so that tomorrow, if at all they are part of the program or supporting the program, it would be very helpful. Lastly, they should understand what are the testing strategies that is adapted in each of these sites, and they should also be able to justify why it is used and how it is done. So with this, I would like to start the session on HIV Sentinel Surveillance. A brief background why this HSS or how it came into existence. Most of us might be aware that HIV Sentinel Surveillance did not exist in the year 1985 because the worldwide it was witnessing the occurrence of HIV cases in other countries, India also woke up to the situation and started doing zero surveillance program by ICMR. With this, eventually they found out the first case of HIV in Tamil Nadu of India. Later on, they wanted to conceptualize and gain on the existing surveillance program in a formal way. So they thought of introducing HIV Sentinel Surveillance, which was introduced in a very few selected cities, most of them urban cities. It's almost like a piloting the concept which they conceptualized then. HIV Sentinel Surveillance was almost piloted in few of the cities in 1994, but the full-fledged HSS was formally established as annual surveillance system in the year 1998. So a year to remember in the field of HSS is 1998. Over time, HIV Sentinel Surveillance has evolved into one of the largest and most comprehensive HIV surveillance systems globally. In fact, India should be proud of what it has done, but no compliance. We have to consolidate on what we have already gained and move further with adopting the latest strategies. Otherwise, we might have to lose the gains what we have already achieved. Now, I would want all the participants to understand the basic concepts of surveillance as well as what this HIV Sentinel surveillance is. Most of us are aware of what is surveillance. Surveillance, as per the definition, goes that an ongoing systematic collection, analysis, interpretation, and dissemination of data. All these are wonderfully done in the field of HIV in the name of HIV Sentinel Surveillance, which I will touch upon in the next few slides. But after collecting, what are we using it for? The data regarding health related event is used for putting it into a public health action. Otherwise, our data will not have any meaning. So it should serve its purpose. The major action would be to reduce morbidity and mortality and to improve health. Putting it in the terms of HIV, what it actually means is a system of monitoring the HIV epidemic among specified population groups by collecting information on HIV from designated sites called as sentinel sites over years through a uniform and consistent methodology that allows comparison of findings across the place and time to guide the program response. A wonderful definition coined by NACO for HIV Sentinel Surveillance. Basically, it means that we have certain sites identified called as sentinel sites over a period of years, and for a particular period of time, we monitor the it may be biological data what we are collecting, or it may be behavioral data what we are collecting, but it should be uniform and consistent across the country. That is the role where I, along with my other colleagues, SST, it may be SST members or state AIDS control societies or the regional institute or the NACO, all are striving hard to make it consistent throughout the country. Then only it would be comparable, and then we can compare with the global figures. Otherwise, the figures which we generate or the analysis which we make on the data collected would not be very useful. But I must say, NACO, along with all its subordinates, has done a wonderful job of generating the data which is comparable globally. Moving further, what is this Sentinel site? As I already said, it is a designated service point or a facility. For each of the population group, it differs. For example, if I am speaking of the ANC site, it is antenatal, that is ANC OPD, either in a medical college or a taluka hospital. If I am speaking of a high-risk group population, it can be a program provision in the form of a TI site where people walk in to receive other services. It may be related to their sexually transmitted infections or any such kind. Those may be the service point. If I am speaking of a prison site, it has to be prison where they are staying. So designated site vary according to the population group which we are speaking of. But within that population, it is a fixed point or facility where blood specimens and related information are collected from a fixed number of eligible individuals from a specified population group over a fixed period of time, periodically, for the purpose of monitoring HIV epidemic. So basically what it means is, it is a fixed site where they walk in for some other services, and also blood collection or other data collection can happen. That feasibility should be there. Otherwise, we cannot just choose a sentinel site where our required population may not provide their blood sample, or they are unwilling to share their information. Such points may not be of useful, but these sites are thoughtfully selected where nowadays, I think just I will in the next few slides I will tell you how it has evolved from a very few sites to large number of sites. That is how India is progressing in having nowadays it is almost probably one of the largest surveillance related to HIV happening in the world. So what it means here is, over a period of fixed number of eligible, for example, it's in the ANC site, it is 400. We are not changing it. If it is a duration, it is fixed for 3 months. So that 400 individual in every site are recruited over a period of 3 months across the country. That is what it means. It helps us in monitoring the HIV epidemic. We know the trend. So basically, what are the objectives of HIV Sentinel surveillance? These objectives have slightly evolved over a period of time. And these objectives, whatever I am presenting in front of you, is from the latest, that is 2025 HSS, also called as HSS Plus. The first objective is to provide the latest status of level and trend of HIV epidemic among the surveillance population. If you want to check HIV prevalence in ANC human, yes, we compare it right across from the previous year, right from 1998 till 2023, you can compare, or make from 2008 onwards, you can make a comparison whether it is in a increasing trend or decreasing or stagnant. For all these will help us in knowing whether our interventions under NACP are really working well or not. If not, we have to change or adapt to the local situation. The second important objective is to provide evidence on geographical spread of HIV infection and identify emerging pockets. The second objective is very, very important, in which HIV Sentinel surveillance has a great role to play. It's because of this HIV Sentinel surveillance, many new sites are added, and over a period of time, it has been ensured that at least every district of our country has one site, so that we will know what's happening within the district. Otherwise, earlier days, HSS, we had very limited sites. We may not be able to identifying the geographical. So they started to with an objective of HIV Sentinel surveillance to provide evidence whether HIV is actually spreading. So as we are terming it as a epidemic, if we put R naught of HIV somewhere, it is ranging from 2 to 5, then definitely it is in the range, it may be termed as an epidemic. We have to halt and reverse it. In that sense, India has done a tremendous job. So the program would actually cross check whether we are reducing the spread of HIV, as well as if there are new emerging pockets, reason for the same might be looked into, addressed. If we don't look into this, these emerging pockets might give rise to another wave of epidemic. So that is how the program looks at it. Objective 3, the third objective, is to prioritize program resources and evaluation of program impact. As most of us, being in the field of community medicine and public health, knows that resources are always limited, but we have to put it into best use. And HIV Sentinel surveillance, the data and the information provided out of it help us to prioritize and evaluate the program impact. The fourth objective is to contribute to the estimation and projection of HIV epidemic at national, state, and district level. This fourth objective is new into the HSS, which was not quite well visible in the early days of HSS. Of late, in the past few years, this has become more prominent, and especially I would like to tell this district level estimation and projection of HIV epidemic has been made an objective, which was not there earlier days. It was restricted to national and state level. But with more sites being added at all places, as I said, every district, at least they have one site. Then, yes, we have some data. That is how we can set our objective that we can estimate and project it at a district level. I'll speak as I progress into the explanation of the methodology part. With all these, what are major applications of HIV Sentinel surveillance? So as the objective stated, we need to estimate it as well as project the burden of HIV at state and national level. Of late, even the district level estimation and projection has been added into the picture. Just for the benefit of postgraduates, I would like to mention here, India is using the latest software and mathematical models in which the HSS, HIV Sentinel Surveillance data is fed into. Specifically, it's called as Spectrum 6, version 6.33 is used. UNAIDS suggests that this software shall be used if we want to make or compare our data with other countries globally. So in this sense, India is using the latest technology to estimate and project the burden of HIV also. The second important application is program prioritization and resource allocation, which has been already foresaid in the objective. Definitely, this helps us to reallocate the resource. Say, for example, there is an emerging pocket. We have to just see that the resources are mobilized or utilized in an appropriate manner. There was a star question probably in Lok Sabha in 2023 asking for what has happened right from NSEP 1 till 5 now. Okay, so 4 got extended. Now we are in the 5. 5 will end by March 2026. That is why NACO is geared up to consolidate on the so far whatever achievement it has made, and we move forward probably to the next phase of NACP. And this HSS data, I must say, it's a treasure house which gives the national body, that's NACO, to implement its national program effectively and see that the global targets are reached in relation to HIV. It also helps to assess the evaluation of the program impact. Just now, as I was telling, so when a question was raised, you have been given so much of money right from NSEP 1 to NSEP 5. What's the progress? The government was in a position to show the evidence that what good things or how the program has impacted in halting the progression, reversing the trend. So it almost showed the data, so showed that nearly 87% reduction in the HIV prevalence as well as deaths related to HIV was shown through the program. But as I said, government also stated that it cannot be complacent and looking for the emerging either hotspots or there are some districts or states where there is still it is not reversed. Some are in an upward trend. We have we in the sense the government as well as the bodies has to address this. Advocacy, as rightly said, the HIV Sentinel surveillance provides a good evidence to advocate for either reversing or halting or reducing the deaths or the prevalence. And also of late, the importance has been pushed into reducing the new infections of HIV. Moving further, as I was narrating how HIV Sentinel surveillance came into, this is a timeline which particularly tells us how HIV Sentinel surveillance has evolved, and I would be briefly narrating what changes has actually taken place at this place. With the paucity of time, I may not go into detail, but let me try to be brief and narrate what events has taken place, because it's almost more than 2 decades where HIV Sentinel surveillance has played a major role in providing evidence, and the impact is really good. So as I stated, 1985, though HSS was not there, the zero surveillance was started because there were cases being reported elsewhere. So India also geared up to the situation, and initially they thought of, let us screen the people who gets blood donation, as well as the people who report with sexually transmitted infections. Then they found out that the first case was reported. Then, as I said, the piloting was done in 1994, followed by formalized annual surveillance. So here there was something between 1998 to 2008. Every year there was an annual HIV Sentinel surveillance undertaken by NACO. But interestingly, the sites were very minimal, and most of them situated in the urban areas. That is why, though the data was generated between these 10 years, the decade might not be as robust as what we get now. But during that time, when the earlier phases of NACP 1, 2, 3 were running, so at least the 1, 2, it was quite very useful for them to adapt the program as per the evident findings in the HIV Sentinel surveillance. This is where uh, data collected with a consistent methodology across the country, or at least touching upon the major states over a period of time, all the states, and over a period of time touching upon all the districts, will help the program to be implemented effectively and address one of the epidemic disease to reduce its impact. So after 2008, that is between 2008 to 9, it was decided that instead of annual surveillance, let us go for biennial, that is once in 2 years. Okay, 2010-11, 12th round was there. Before proceeding further, I would also like to put into statement that 2006 is almost considered as a watershed event in the field of HIV Sentinel surveillance, because there was lots of expansion of the sites, and also the methodology improved, and seen that the evidence generated related to HIV was much more better as compared to the previous rounds. The next, after 2 years, that is 12-13. Whenever I say 12-13, it started the preparation, the TOT, etc., starts in usually in the last few months of the previous year, and the actual surveillance might happen during January. For example, this 2025, what I have been monitoring, the preparation started in 2024, last 3 months. They trained us through the TOT. We trained the site professional personnels, and then they in turn started implementing right from January 1st to March 31st, 2025. So this is what I mean when we have this 2 years into the situation, but still it is a biennial. 15th round. So after this 15th round, there were many changes. The 16th round had a great expansion. There were nearly 833 antenatal clinics spread across 35 states and union territories. So it means India for the first time had almost at least one site in majority, except few districts. Most of the districts had one site. So having this site is very important. NACO also realized that there were some sites which were closed as a site in the previous round of HSS. The reason was these sites were not being utilized by the people. Say, for example, if you have a site and provide them a sample size of 400, okay, you have to recruit 400 antenatal mothers. If 400 antenatal mothers are not turning up, and we have to check into the inclusion exclusion criteria, then their consent, etc., if such is a situation, they might fall short of that. So if such sites are not being utilized by the either the key population or the population group of HSS, some were dropped, or there was a revised strategy. Instead of dropping a few centers, they brought in some additional center nearby which shares similar geographical and other context in the district. They thought of combining these sites are called as composite sites. Instead of having one site, they may have up to the max is instead of having one, 2 to 5. So max is 5. So they may have another site supporting or another 3 to 4 sites supporting. So put together, total of 5 sites together may form a composite site. 5 is rare, but usually 2 to 3 sites combined together make a composite. All these expansions kept happening 16th round onwards. Similarly, in 2021, 17th round, there was a major change which was termed as HSS plus. It's because instead of focusing only on HIV biological marker which we are checking, so the biomarker was expanded to another 3, that is HIV, syphilis, hepatitis B, and hepatitis C. The advantage of bringing in this is there is already a well-established HIV Sentinel Surveillance system where we already collect a sample. Why don't we check for the prevalence of other diseases that are transmitted through similar route? That's the thought, and they and the capacity was largely upgraded during this time. That is why the term HSS plus, the expansion both in coverage as well as the biomarker expansions touching upon 4 diseases. 18th round was in addition to what has been gained so far, that is a large expansion of population coverage. There were 1,557 sites covering 8 population groups, out of which 600 sites were only from high risk group and bridge population. I'll just explain in the next upcoming slides what these high risk groups are and bridging population. That's the advantage of expanding, so that the more sites you have and the consistent information you are getting from these sites, we will get a good understanding of what's happening in these districts, right? Why there is a upward trend, why some districts are not showing much progression, though the state might boast that okay, we have reduced the prevalence, but there are some districts within, there might be some reasons. We have to understand that. So expansion definitely helps in gaining this information, which is very useful for the program to adapt to the situation and move forward. The 19th round, the currently running, so we are exactly midway between this 19th round. It started by 1st January of 2025 and it will end by 31st March 2025. That is data collection. Data means here both the biological data and the behavioral data. So this is happening related to ANC and prison. High risk group, it will happen probably either during this year end or next year. So this is a bit busy slide, but I kept it for a purpose just to make the participants understand. If you focus on this 1998, which I was referring to, okay, the first HIV Sentinel surveillance that it just took place in 76 and 92 ANC. Initially, these STD clinics were also made ANC site. After 2012-13, it was stopped. Okay, so followed by this, the biological IBBS, that is integrated biological and behavioral surveillance, was done in 2014-15. So these STD clinics site were closed, only the ANC site were retained. Interestingly, if you observe this third row, ANC rural, as I was said, initially it was situated only in the city. The urban and rural people's behavior might be different within the district. To understand this, they brought in the site should be expanded beyond the urban category, that is to the rural. The rural sites were added in 2003. Like this, if we closely look into the progression from 1998 till 2025, there are so many changes. At least in this, or spanning more than a decade, we can observe gradual increase of the antenatal sites, addition of the high risk group sites which were not there initially. For example, these migrant sites, which were not at all there till 2004. Only by 2005 onwards we have, even in Karnataka we have this migrant site. The transgender sites, which was not touched upon, okay, so the site was specified 2005 onwards. So this was the reason I have kept this slide, but rest of my slides have most of the maps or graphs to make the understanding easier. So this is again gives a fair understanding of the white colored districts mentioned in HSS 2003 are there were no sites. If you can observe, most of the sites are, I'll just choose the pointer so that it becomes easier. Yes. So the red color marked are, it has sites, that is 2 sites. Most of the southern states had this HSS sites. This is taken from my ANC site. Okay. And if you observe, large portion of the North Indian states did not had even one site. That means probably we were not generating information from all the states or districts in the country. If you observe from the left graph to the last graph, that is HSS 2012 and 13, here at least they have tried to have one site in majority of the districts of all the states in the country. Now, if you observe in 2023, though I have not put up the map, here this graph shows you right from 92 sites in 1998 till 889 sites. So in 2025, we have further more, touching upon more than 1,500. So what it means, this is only ANC site. Okay. If you add HRG, high risk group, also to this, it will amount to 1,500 plus sites. So that's a huge growth and expansion of the sites in India related to HSS. This is again an interesting slide that shows state-wise distribution of ANC. Of course, we have to understand that as per the population, we may have to have the sites. For example, the smaller states like Goa, Union Territories may have lesser number of sites, whereas the larger states with large number of population will obviously have more sites. But it was seen to that at least one district has one site, and also moving further, at least each district has one urban site and one rural site. By this 2023 as well as this 2025, it has been made a reality. Interestingly, as I was narrating the events that happened from 1998 till 2015, the almost after 2012-13, so once this IBBS was also involved, 2014 onwards, second generation of HIV surveillance, and of late in 2016 onwards, we term it as HSS plus, adding upon to more diseases into the surveillance system. So this second generation HIV, presently what we are doing is second generation. The first generation has been done in the past. We learned, we added some elements to it, either in the form of expansion of the sites or adding biological markers, which we are expanding our kitty to ensure that instead of one disease, 4 diseases are being under the surveillance. So the key features are tailoring the HIV surveillance system to the pattern of epidemic in the country. So as I said, epidemic is not same across the country. Epidemic is not same across the state. So that is how the second generation HIV surveillance has helped us in getting the information, both biological as well as behavioral data from the district level, and using the latest technology, India is able to estimate and put it across what's happening where and why it is happening, and let us address this. So this is possible only because of the second generation HIV surveillance. The behavioral surveillance for collection of information on risk factors and practices. So the 2014 IBBS survey gave a lot of information related to the risk factors that are involved with transmission of this disease, especially among the high-risk groups. If we do not address this, the program might not be efficient. So that is how the second generation HIV surveillance has helped us bringing in all these, both biological and behavioral surveillance, into a common HIV Sentinel Surveillance, making the best use of other sources of information. Let me narrate you with my field experience. I think in the past 3 surveillance system, it was not done previously. Now we have data that is being collected from the sites. but there is already program data that is available within the ICTC for the people walking into the ICTC or referred, they get their testing done. The antenatal woman might undergo the PPTCT services, where obstetrician may refer her to even check for syphilis as well as HIV, sometimes hepatitis B, C. All these past information was also collected and triangulated. This triangulation is possible in present day HSS Plus. That's what, when I was referring to the software, that Spectrum, it's a very nice software that takes into account not only the HIV Sentinel Surveillance data, it also takes into picture the existing, what's happening within the program, as well as other surveys that are being conducted in the country. So then we will be able to figure out and put it across, okay, this is what happening related to either say prevalence, and off late in 2023 and 25 they are even trying to assess the incidence, which is most difficult in HIV. Even WHO refers that there are 3 to 4 methods of estimating the incidence, because most of the data what we are getting in HIV Sentinel Surveillance is prevalence data. If you want incidence data, we have to have a special way of calculation by getting into this triangulation related to the existing information. This is what it means. And also better use of surveillance data to plan prevention and care interventions, without which probably we will not be able to bend the curve and see that the UNAIDS target will be achieved. When I say UNAIDS target, there is a HIV cascade. What it means, I think you may be aware, but I will reiterate the point and also give you an update what has happened within India in 2024. So the UNAIDS targets are 95% of the people who have HIV should be aware of the diagnosis. And those who are aware of the diagnosis, they should be, that is, those who have tested positive for HIV should be treated. Sorry, am I audible, sir?
Yes, sir.
Okay.
Yes, you are audible. You are audible.
Thank you, sir. So among those who are put on the treatment, that is antiretroviral treatment, so of late, I think 2020 onwards, we have mostly TLD regimen, which is there. 95% should be virally suppressed. If you NACO responded to this UNAIDS and has adapted in its phase 5, setting it targets, and the achievements are a bit remarkable. I'll just show in the next slide. See, this is the achievement that has been shown by the year of 2024. 87% of them are aware of their HIV diagnosis, and 88% among those who are aware are treated for HIV, and among these people who are treated, 97% are virally suppressed, thanks to the deltagravir combination medicine that has really be a remarkable achievement in achieving this viral suppression. But what I must inform all the participants is, though we may state and boast that 87% of them know their diagnosis, but if you closely look at the data out of the HIV Sentinel Surveillance, there are some districts, there are some states where large number of population are not aware. Even within the same district and state, sometimes it may be ANC women are aware, whereas the high risk group people are not aware, the population group is not aware, the high risk individuals are not aware, and even the treatment might not be adequate. This is where we need to look into the data. Of course, when we make aggregated data, it appears very rosy picture. I appreciate the government and its all the associate agencies for making it achievement, but even government in its document reflects that we have to focus on these areas where we are lacking if we want to achieve these targets. There was an interesting paper, I think in 2020 21, if I remember correctly, so which compared are we on the right path. It was comparing the previous one, 1990 targets, okay, which was set for 2020. They compared the African countries and Indian progress, and with such progression, they the authors have given a nice information that yes, we can achieve if it continues focusing on to see that wherever these emerging hotspots or the pockets where it is rising, or the district or the states where it is on uprising trend, has to be addressed, and probably we should be able to achieve this. So by and large, if you look from a national or a state perspective, we are on track, but there are some states which are not on track. We have to bring them on track without stigmatizing any district, any state, or any population. We have to take into consideration what are the reasons and address appropriately. Now, briefly, I will narrate you how the HIV Sentinel surveillance is actually implemented in our country. Okay, so though the slide is busy, I will just briefly tell you. At the apex, we have National AIDS Control Organization, NACO, at New Delhi as a nodal agency for all policy, strategy, and planning. Works very closely with AIMS New Delhi, okay, as a nodal agency for coordination and supervision, analysis, and documentation. So these two agencies has full access to all the data what we are feeding into. Towards the end of my slides, I would also narrate you how the actual data of HIV Sentinel surveillance is managed. I will touch upon briefly, but let me tell you at this point, the data is accessible to these agencies where they can take almost like a real-time data. Under these, we have central team as well as regional institutions, reference laboratories. I would like to highlight a particular, that is because from this RI, I have also been trained and touched from the last decade. I'm thankful to ICMR NIE, which has introduced me and given an opportunity to work for the national program in our country. So likewise, we have 7 regional institutes. They are responsible for technical validation of new sites, training, monitoring, supervision. They have trained us. We in turn train the site people. They have whenever a new site, I just narrated you now. So right from around 72, we have gone to 1,500. Such is an enormous expansion of the sites. Whenever a new site comes into picture, it has to be validated by the RI. Monitoring and supervision, right from RI people will also do. The State AIDS Control Society in Karnataka, we call it as Karnataka State AIDS Preventive Society, KSAPS. Along with them, we as a state surveillance team members go to these sites. So hope you are seeing this red arrow. These sentinel sites in ANC, it can be a ANC OPD where I was referring to. In case of high risk population, it can be a targeted intervention site or a drop-in center or whatever. If it is a migrant, like long distance truckers, it can be a migrant site. For prisons, obviously, it is the selected central prisons. So various levels of supervision happens to these sentinel sites, right from SST members. And I am one of the SST members. Like me, there are other SST members in Karnataka as well as other states. Thanks to all of them, as well as SACS, RI, NACO, and New Delhi, AIMS New Delhi, for giving us the insight, support, and ability to effectively monitor and supervise. Let me, with my experience, tell you this monitoring and supervision visit is one of the greatest strength of the program, that is HIV Sentinel Surveillance, because without this, the data generated, both biological and behavioral, would be of very little meaning to the national body. So we not only me, others, like you, it can be other SST members or SACS or the RI people, go to the field level and actually cross-check how they are doing, do a supportive supervision, and see that the data is generated very in a robust manner, adhering to all the protocols. That is the strength of implementing this HIV Sentinel surveillance. So this is just, I have highlighted where I have undergone this TOT and been in touch since last decade. Thanks to all of this. Yeah, this is one important model which was given by probably in 1990s. So the Team Browns, later on in 2006, the publication is probably by 2006, if I remember correctly. So Tim Brown of comparing it with the Thailand and Indian scenario, gave a model of how HIV is spreading in India. So here, the authors make an important distinction between this white color is uninfected, the people who are not infected with HIV. The colored one are infected people. For example, there are people, males who are uninfected, and there are people, males, the sub portion of that, okay, smaller portion may be infected. These infected male clients may transmit HIV to their spouses, okay, females. Then this female who was uninfected, not infected, became infected with HIV. So this female might transmit to the children, that is mother to child transmission. Now there is a concept called as EVTH, elimination of vertical transmission of HIV. This is of utmost priority because we have to meet the UNAIDS target. So there are red color marked population. These are high risk groups: men having sex with men, hijras or transgenders, female sexual workers, or injecting drug users. So these people may contact with each other. Either, for example, the IDU having a sexual contact with female sexual worker who is infected with HIV can contract, or IDU by sharing the needles and other might be already HIV infected who may transmit infection to. That is why the two-way arrow. Similarly, the FSW and MSM. So if later on I will show some of the slides if I have time. So I'll just rush through those slides because of the paucity of time, but definitely I will show you how the prevalence, though we state that India has a lower prevalence of HIV, but these high risk groups has really higher prevalence, which is, and also their transmission dynamics is quite different as compared to this. This is one model which was adopted. Later on, this was taken to EPP based upon which the estimation of HIV was done. Now we have moved beyond and using the Spectrum software. So here, this is what I want to highlight you. HIV Sentinel Surveillance Plus program has expanded to 8 groups. Okay, earlier prison was not there. Now prison has also been brought. The first group is antenatal women. We call these as ANC sites. The second, prison sites where the convicts and under trials are recruited. The high risk groups, there are 4 high risk groups actually: female sexual worker, men who have sex with men, transgenders or hijras, injecting drug users. There are 2 more population which are vaguely termed under HRG but belong to a subset called as bridge population, long distance trucker and single male migrant. They are called bridge population because they may transmit infection from this high risk group to the general population. For example, a long distance trucker who travels more than 800 kilometers one way might halt at a place, solicit a female sexual worker, may contract the HIV infection, come back to his hometown, transmit the infection to the spouse, and spouse in turn may transmit the infection to the child. This is how the annual new infection might increase if we don't focus on this bridge population. So I will touch that when I discuss about HRG. So the first 5 to 10 minutes, I will touch upon the ANC sites, how it is done. But why are we selecting antenatal woman as a representative of a general population? It's because we cannot just recruit from the general population, which is so large, and don't seek in a regular fashion, and they may not agree for the providing, especially the biological sample, that is blood sample, right? But these pregnant women who are largely homogeneous coming to an antenatal woman are already getting the service done through the routine program. They go to the PPTCT, give their blood sample for testing the same HIV. They also get testing done for syphilis and other routine testing. So this offers an excellent opportunity. Additionally, since they are pregnant, it has proven beyond doubt that they are sexually active segment of the general population. That is what we want. If there are dynamics of HIV transmission, it has to be sexually active, which is one of the prominent mode of transmission of HIV. Second, the linked anonymous testing, which is followed in this HSS plus, is possible only when there is a testing, that is blood specimen collection. Otherwise, if it is not there, it would be only behavioral risk factor. For them, others may also agree, but for getting this blood specimen collection and seeing that there should be a anonymity as well as linkage to the program, ANC woman would be the best answer. So where they are already getting tested. And pregnancy being physiological will not induce any bias, and antenatal care are largely available, whether it is a North Indian states or South Indian states or the Eastern states or the Western states. This is the advantage of choosing ANC as a representative or a proxy for general population. So this is a strength, as well as to some extent it may stand as a limitation. But by and large, since the beginning of HIV Sentinel surveillance, these antenatal women are representing for the general population. And I would request participants to know this, why they have been selected. The inclusion criteria are very simple, just two criteria, that is their age should be between 15 to 49 years and they should come for the first time during the current round of surveillance. As I was stating, the current round, that is 2025, they should come for the first time during the current. For example, if the woman is coming for the first time today, she will be included. If the woman has visited on January 12th, 2025 and coming again today, she will not be included. That is what it means, exclusion criteria, where the age is not beyond this, and if she has come for second or more time. In a nutshell, methodology of ANC clinic is, this is very helpful for postgraduates, easy to remember. Okay, sample size is 400. Every antenatal site, they have to recruit 400 antenatal women over a period of 3 months. That 3 months will be decided for every surveillance from NACO through its RI. Once in 2 years, it's conducted using the consecutive sampling. Consecutive sampling, I think most of you from community medicine background or research methodology background would know this. So in the order they come to an antenatal clinic, they have to be recruited. That's what it means in simpler terms. The reason for having this consecutive sampling is to eliminate selection bias. There is a strategy called as linked anonymous strategy. This is again a major change in HIV Sentinel surveillance. For the benefit of postgraduates, let me tell you, in the first generation HIV Sentinel surveillance, it was unlinked anonymous strategy. Okay, so later on it was converted into linked anonymous strategy, because there was a felt need that these women who gets any woman who gets a positive result of HIV or syphilis or hepatitis B or hepatitis C cannot be given that report of the surveillance, because it is done for the report, which is just a two-test strategy. You all know that for giving the HIV report, at least 3 tests should be done. So it is a 2-test strategy done for the surveillance purpose, but we are not giving the result. But if at all she has been tested positive, what to do? She has to be brought under the, at least seen that she is brought under the care of the ambit of national program. That is, whether she is being provided counseling, testing, post-test counseling, and antiretroviral treatment. Let us just revisit that UNAIDS targets. Okay, if we have to meet that, they should know their status, they should be put on treatment, and they should be having a good virological suppression. If that has to be there, someone has to bring this woman under the care. That will be done by linking this in a book called as HSS register. No personal identifiers will be written except for the unique ID of the pregnant woman who has come to the clinic and sample number. No other details of the antenatal mother, like phone number, name, etc., will be written in that. That's the advantage of having this. So now I will just narrate how it is done, because it will take a lot of time to explain this. I think for our site planning, we take it in detail. They undergo training for the entire 2 days. So I will just cut it short. For the benefit of PG, you should know the process, But since you are not actually implementing, I will not go too much of details into how actually it is done, but I will definitely narrate at each of the population how it is done. For antenatal woman, she comes to a clinic, then they will be explained about that this is a HIV Sentinel Surveillance site. They would be given a participant information sheet to read. If they are literate, if they are illiterate, it will be read out and explained to them in their own language which they understand. If they are illiterate, another LAR's consent will be taken for that. Once they consent, they enter the details in the HSS register. Even if they don't consent, their routine treatment will not be hampered. So, but the reason for not participating in the HSS will be registered, because this gives us the information why antenatal women are not agreeing for getting their blood tested. Probably they know their status already. That's okay, but that has to be written there. Okay. Once the HSS registry is filled, the data forms are filled. This is where I was referring to biological behavior, behavioral information will be collected. Once that behavioral information is captured in the data form, which is paper based and sent to RI, the blood will be collected. That is 5 ml whole blood will be collected, which undergoes a centrifuge, and out of that serum will be separated and 2 ml serum will be sent for HSS, the aliquot. This 2 ml serum will be undergoing testing for 4 diseases. Let me repeat that: HIV, syphilis, hepatitis B, and hepatitis C. So far, hope it is clear. The only difference is in most of the southern states, we have PPTCT services in all the antenatal sites. In some of the northern Indian states, there are certain antenatal clinics where there are no PPTCT services. Wherever, irrespective of whether it is a northern state or a southern state, if they don't have a PPTCT service, this is the last part I am referring to. Send them to undergo that PPTCT services nearest. You just do a routine blood test if they have been offered. Second thing, you send the sample for HSS if they have consented for the same. This is about implementing at a ANC site. This is interesting thing. I don't know, some of you might have seen, but unless we work closely with the HIV Sentinel Surveillance, I believe that many of you might not have seen this register, where it is a 10-column register where this is what I was referring to, linked anonymous testing. They just mention the ANC register number or PID number of the woman and whether they have given consent. If not consent, the reason for refusal. If given consent, a HSS sample number will be generated. This is what I was referring to from column number 7 to 10, where they capture whether PPTCT service is already provided. Apart from this, they have another column where even their past details of in the past 6 months, what is their status happening in their antenatal clinic about the PPTCT services. So this is what added advantage of having this meticulous registration at the site. This is just a picture that shows that how the bilingual data form in Karnataka, it is Kannada and English forms are provided for the benefit of the local people. In some of the migrant sites where they may not be able to read Kannada, even English and Hindi are provided. Likewise, in different states, the respective local language, it is being translated into and given to that. So it is seen that the data form, since it is paper based, it is suggested to use a ballpoint pen and avoid ink pen, so that this data forms has to reach a regional institute for data entry, which is again done with a quality assurance entered by 2 different people and cross-verified for the completeness. It is filled by the nurse. There are 3 people who are working in antenatal site. One is called a site in charge, usually the medical officer or a obstetrician and gynecologist. The second person is nurse or a counselor, who is usually hired from the ICTC or PPTCT. The third person is lab technician to collect the biological sample, that is blood, and separating the serum and sending it for HSS. This is just the forms. I'll rush through because this is not for your learning, but I have purposefully placed some pictures of it so that you get a glance of what is actually collected in these data forms. They have a site code, sample number, as well as the subsite number. If it is not a composite site, the subsite number will be 0. I'll move further. You should know that it's a unique code generated at every site, because when I said 1,500 sites, if we do not have this unique code, it would be a chaotic situation to check which biological sample or the behavioral information came from what population group. That is why a unique code has been set. The total sample code is 12, out of which 8 belongs to site code, 1 is subsite number, and 3 belongs to sample number. I have just quoted my own district where I hail from. The antenatal clinic in the urban area, we have this first 8 digits as the site code, followed by a subsite. We don't have a subsite, it's not a composite site, and the sample number starts from 0012 to maximum is 400. If there is a chance that the sample is rejected, it may move beyond that, 401, 402, etc. This is important, which has been added in the recent HIV Sentinel Surveillance. If somebody asks what are the recent changes, this is also one of the changes where consent is being taken from the pregnant woman. Earlier days, there was no consent taken. Consent was taken for the PPTCT service or other things, but not for HIV Sentinel Surveillance. So of late, it was decided that thinking of an ethical perspective and a voluntary nature and the person's autonomy, so it was decided that ANC woman also has to give consent, at least to this row 1, 2, and 4. That is, they should consent to interview, otherwise there is no point in talking to the woman. But even if she don't consent, her routine services should not be hampered, that will be given, and she should provide the blood sample, agree for testing for all the 4, but the report will not be given of the surveillance. This information has to be passed on, otherwise they think that some of them start asking, okay, I have given the blood sample, give. No, the same blood sample aliquoting, one of the aliquot can go to the PPTCT or ICTC. That report can be given to the patient, but not the HIV Sentinel Surveillance. The fourth point is publication and dissemination. Without that, I think none of the reports would be invoked. So if everything is done and they don't agree to publish or disseminate their anonymized and combined data, maybe it is of not much use. That is why we train them to have consent for at least 1, 2, and 4. If they have for all 5, well and good, but at least mandatorily 1, 2, and 4th point. This says they have to mandatorily encircle after getting the consent. Here I have an interesting information. When I show you some of the slides showing the comparison of prevalence, there are some states which has high prevalence. It's not the only reason. What I think the behavioral risks what we are collecting here is, did your spouse or partner reside alone in another place or town away from you for a work for a period of longer than 6 months? So of late in this 2023 report, it has been found that there is some increasing prevalence in the states of Bihar, Punjab, West Bengal, etc. Why? One of the reason might be this migrant status. Okay, they come to other states, stay for a longer period, they might solicit and come into the high risk group, contract the infection, go back to their hometown, and if the spouse can get the disease. This is also this is how us the questions placed in the data forms have been designed very nicely by NACO in consultation with other agencies. That is why I like this question which has been placed in the data form, which I thought that I should share. Likewise, there are so many, more than, I think this time we had 32 questions. Earlier we had 40 questions. Some questions were trimmed. There is another area which actually, this is a point which helps us in knowing whether there was testing of HIV prior to this ANC visit. So all such data are being collected that cumulatively consolidates at a state level and the national level. That is how the program gets into. So once this nurse or counselor fills the data form, she has to attach another sheet called as data form transportation sheet, where she fills up all the details, including the sample numbers and the number of envelopes. So finally she signs and sends it to RI. For the southern states, 5 states, we have a regional institute Chennai. Likewise, for other states, respective RIs have been designated where they will send. The samples will be sent for the designated labs called as state reference laboratories, SRLs. Okay, so for my district, it is Hubli KIMS, which is a SRL. Likewise, for different sites, there has been earmarked and they have been tagged up to these sites. The sample has to be sent with the sample form transportation sheet. The data forms will be sent with the help of data form transportation. All these will be uploaded in the digital platform. Though it is a paper which will be sent along with the data form, they have to upload even in the digital portal which has been developed by NACO and RIs. One of the interesting thing which I want to inform the postgraduates is, we may think such a large number of sites, large number of data is being generated in India. Is it really maintaining its quality? Yes, there are quality assurance methods inbuilt into this called as inter-lab comparison. All the positives test results, whichever sample has a positive test result, this sample will go for testing from another designated or recognized lab. Both should get positive. This is concordance. This all we know. Okay. Interestingly, for ANC in 2023, there was 100%, nearly 100% concordance for HIV as well as negative samples. Say 5% of the even negative samples are sent and all the positives are sent. Whereas slight reduction in syphilis, because interestingly, even let me not tell you. So in another population group in one of the lab in Karnataka, there was a discordance. If discordance is more than 10%, all the samples related to whatever biomarker from that lab means there may be 20 sites attached to that lab. NACO doesn't take it into account for estimation or the calculation of the prevalence or put it further for estimation and projection. So this is the level of rigor built within the HIV Sentinel Surveillance. That's the whole purpose of putting it. So you can see the concordant results. It's pretty high. Yes. I thought initially that I will explain the process, but you would be more interested in knowing also what was the result in the or the impact of or at least the utilization of the HIV Sentinel surveillance. So it helps us, as you just read and I explained that one of the objective is to check the prevalence trend. Yes, here it is. So right from a higher prevalence, more than 0.8 to now we are 0.2. But still, though we boast that it is 0.2, there are differences within the states and districts, so that we have to be aware of. This is one interesting graph. Though it is busy, I have purposefully placed it, which I have taken from technical report of 2023, that is very recently released. So here I have just animated it so that you can see here the states marked in red circle has a increasing trend. Forget about the stagnation. It is increasing. The prevalence is almost increasing and some states are stagnant. Ideally, we should halt and reverse, right? But here it is reverse. It is increasing. That is the alarming trend which has to be addressed aggressively in the program, but without stigmatizing any of the state. So 10 years, there was real game change. You can see just I put it to highlight how the HIV Sentinel surveillance helps the program in it's not only because of HIV Sentinel surveillance, because we were able to track something, compare, make a understand why it is transmitting in this area or in this group. We are able to implement the strategies of NSEP or adapt the strategies of NSEP as per the evident findings. So here you can see right from 1992 to 2023, definitely the curve is bending and we are in a declining trend, but we have to look into a few states which I just showed you in the previous estimate. Interestingly, this graph B, though we have reduced the prevalence, but what is our population size? We have a huge population. In that sense, the number of people living with HIV is nearly 25 lakh people. It means out of this 25 lakh, more than 53% reside in the southern states of India. When I said that we have more sites, we have lesser prevalence in southern states, let us not be very happy. It's because the service consumption of these people living HIV is definitely more in these southern states. It may also increase in these northeastern states. Gradually, it may also increase in northern states. So what we have to look is not only focus on the prevalence, we should also see, because with good viral suppression, that's another interesting data. So let me know, I have not put that graph, but I will narrate you. So more than people who lived more than 50 years were very minimal during the initial rounds of surveillance, but the recent 2017 onwards, now 23 data is evident, people are surviving beyond 50, that is their age of 50. That means more number of people are going to live with HIV, so we have to address and cater to their needs. This is another very important, and of late globally, the new HIV infections is being compared across the different countries. If you want to reduce that epidemic and meet the UN aid targets, definitely we need to cut down on this new HIV infections. But strangely, if you observe the past 3 to 4 HIV surveillance from 2017 to 23, there is no much change. There is a difference, that is a smaller evident difference, but it has to be more if we want to really avoid large number of people living with HIV seeking services from our country. So another graph that shows statewide. This gives you a clear picture where the prevalence rate is so high in some of these northeast states. But as I said, without stigmatizing, we have to understand what may be really cause for this higher HIV prevalence. And let us not be just getting away with this data. The southern states, though it is labeled as light green or green with a lesser prevalence, because of the larger population, we have more proportion of people living with HIV here. So, okay, the prevalence rate might be less, but the absolute number of people living with HIV is more in these southern states. As I was telling, more than 53%. Moving on to in the next 5 minutes, let me touch upon prison sites. This has been a recent addition in the past 3 HIV Sentinel Surveillance, labeled as HIV Sentinel Surveillance Plus, which is quite interesting. In Karnataka, we have 4 sites: Bengaluru, Mysuru, Belagavi, and Gulbarga. It was my privilege, along with my other SST members in Karnataka, to train these people so that they are back implementing the HIV Sentinel surveillance in their respective area. But what actually happens within the prison, where it is such a restricted area where they don't give access? Okay, so fine. So without revealing any of the personal information, I would just tell you what the methodology is followed here. In the prison, 400 people has to be recruited in the same 3 months, that is January 1st to 31st March 2025 for this round. Okay, 19th round. It may change for further rounds. It is again biannual. Here, random sampling is method followed. If you just recollect, for ANC, we are following consecutive sampling. What is this random sampling? In research methodology, we are all familiar, but what is random here in prison? Prison, they have a list of persons who are convicted or under trial in that. From there, they prepare a master list. From that, they choose certain people, send it to RI, get it back, and only these selected people who has the random numbers returned will be interviewed. If they consent, then they will be recruited and their blood sample will be collected. So the case definition is very simple. He should be that is a male, convicted or under trial, both are okay, and inmate of the prison, 18 years or above. If their age is also not fitting, we are excluding them. Testing strategy is, this is quite contrast with the ANC, that is unlinked anonymous testing with informed consent. See, even though it is a prison, we are taking informed consent. The probable reasons for keeping it unlinked anonymous testing is most of these prison inmates are already receiving service through their routine ICTC. Most of them, even the 2023 data shows that they are undergoing routine services, and to avoid any of the mistaken linking of these people and revealing the data, especially with these sensitive population like prison inmates, they have avoided it, linking it up. So here also it is same, serum is collected, the blood sample collected, the serum will be going for testing for diseases, that is HIV, syphilis, and hepatitis B and C. Inclusion criteria, I already told, male 18-year-old, either convict or under trial. As per the basic definition, convict is who has been found guilty of a crime sentenced by a court of the land of the law. Then under trial is who has committed to judicial custody, not yet proven. So they may be pending investigation or trial, but still we are recruiting them. Inmate is any person who is detained in the prison on the orders. So there are again 3 persons here. Here there will be a medical officer in charge. In ANC, we had a obstetrician or gynecologist in charge, whereas here a medical officer who is usually appointed for the prison will be in charge. Counselor will be playing a major role here, checking for the eligibility criteria, whereas in ANC side, it is usually the obstetrician who first decides the eligibility, and LT's purpose is collecting the blood sample and sending it for the testing. So it is the same, similar, but not same actually. So but what's the difference here is, since it is a random sampling method, unlike in ANC, whoever walked first into the clinic, if they agreed, we recruited. But here it is not. We are going to them because they are already know, we have a list. Okay, a random list of 400 inmates is obtained from the SACs. In Karnataka, it is KESAPs. These 400 people, as per the random number, every day they recruit preferably less than 20. So sometimes if possible 5, but do not cross 20 per day. Once, how they do? They go to the respective person, ask for their consent, explain the purpose of HSS, ask for the consent. If they fit into the eligibility, gives consent, they will be interviewed, filled the data form. Okay, once data form is filled, blood is collected, 2 aliquot done, 1 for ICTC, 1 for HSS plus. HSS plus testing for diseases, it is tested. If they refuse, they write the reason. If they don't come, or say for example the jailer decides that this person is a threat or something, okay, so not recruitable, then also it will not be done. A list of people who could not be recruited will be listed out, and every 15 days that will be sent back to SACs, and through the help of RI they would have obtained another additional list, because we usually send 500 inmate list to the RI, where they provide numbers for only 400 through SACs to the site, where those extra 100 random number generated will still be lying at the RI or SACs, which will be sent for replacement. This is how it is done. Processing, the blood sample, serum is separated and done. So I'll just move further so that to cover up the time, I just tell that HIV, there is 2 tests done. If the first test is negative, it is reported negative. If it is tested positive, it undergoes another second test. Only if it is positive, then it is reported positive. Even this, there is something called as interlaboratory comparison as a quality assurance method. Syphilis, it is retrograde 2-stage testing, 2-test protocol, that is treponemal assay is done on the sample. If it is negative, reported negative. If it is reported positive, the RPR semi-quantitative test is done. The exact titer is reported if found to be positive. For hepatitis B and C, it is just the rapid diagnostic kit. For hepatitis B, they test for hepatitis B surface antigen, whereas for hepatitis C, it is anti-hepatitis C virus antibodies. This is the basic difference. This should be quite interesting for even microbiology people, where they actually do it. And now inching towards the end of this prison, we should note that what is actually documented. Since it is unlinked anonymous testing, the HSS registered data form and specimen should not contain any personal identifier. Let me remind you, these are the prisoners, okay, convicts or under trials. You cannot put up these names and send it across. That will be a blunder if they send that. They should not do that, okay. Only the sample number will be written and sent further. Consent form will have these personal identifiers. That is why the data form and consent form has to be kept separately. This is more important. This we inspect when we visit the site. This is a HSS register kept at prison sites. You are seeing here prisoner unique ID number, random list number, the type of prisoner, planned date. There will be 3 opportunities. Even on the 3rd visit, if nothing goes well and the person refuses or by any means they are unable to recruit, they just write the code. This we train for the site people. That is not required, I feel. But here you should know that HSS registry is a document that helps to note down the details of the people whom you have recruited under HSS. If they have not consented, the reason for refusal of consent is also noted. This is a outcome. This is a report, latest report released of the 2023, for which I had an opportunity as a part of a state surveillance team member to monitor and supervise these places along with my other teammates. Nationally, the weighted HIV prevalence was 1.99% among the inmates. Let me remind you, the general population proxy ANC has 0.2, whereas prisoners has 1.99%, probably because of high risk behavior. Here we may see that under trials have 2.48, which is quite large. So I was telling so these people, if they start transmitting infection to others, there may be a increase in occurrence of cases leading to a epidemic. So over a period of time, HIV is said as there is a terminology called as graying epidemic, because it is almost halted or reversed or something like that. But if we don't address these people like prisoners or high risk behavior people, I'm not equating high risk people with prisoners. I'm just telling that whichever population has higher HIV prevalence has to be addressed, taking care that they do not transmit to other infection to others, as well as these people should know their status, take the treatment, and have a good viral suppression. So this is what this interesting point, I think I just narrated. One of the sites, syphilis, there was a discordance. So this data was rejected. So the entire data from this site for syphilis was not included in the diagnosis, whereas HIV, yes, there was a concordance, they included. In Karnataka, in prisons, it was 1.03, which is again higher in number. There are some things. Are you observing here? Mizoram with a 21 prevalence rate. So it's a pretty high. Punjab 9. This has been picked up as emerging. There might be some reasons that will be revealed through the biological behaviors. So India standing at 0.71, all on those left has higher prevalence among prison inmates, which has to be addressed, and see that at least these persons first should know their status, bring them under treatment, and have a good viral suppression. Then focus on other behavior so that these people do not transmit to other. So the last portion is HRG sites. Animesh sir, sorry for exceeding time. May I have 10 minutes more so that I can conclude this HRG? Okay, so I'll continue. So this is very important because this is a population where the prevalence rate is so high, sometimes unimaginable, that if we do not address this, the transmission dynamics, if it increases, there would be again reversal of what we have gained so far. So there are few terminologies. This should be quite interesting to the PGs to learn. If you are aware, well and good. But if you are not aware, please know this terminology so that tomorrow, if you are working along in the field of HIV or NACP, this would be very helpful to you. High risk group is any population that has high risk behavior contracting HIV. It includes, I already told, female sexual workers or men having sex with men, injecting drug users, hijra or transgender, and 2 bridging population, single male migrant, long distance truckers. High risk individual is the individual who belong to this high risk group. The sampling method here are 2 types. For bridge population, it is consecutive sampling, because the truckers, you don't have a long list of who comes to the site. The migrant site. Okay, the single male migrants also, you do not know who actually shifts from this place to other place for work or other elements. And whereas the people like transgenders, okay, or hijras, or female sexual workers, men having sex with men, or injecting drug users, all these people list are available. There was a huge estimation of this population, they called as PPSC. So they estimated the population size in every district of our country. This is a huge exercise. I must applaud NACO and its other agencies for doing this wonderfully. Now we have at least know the population which is existing, so that it can be worked upon. The testing strategy is, so for the people whom we know, the sampling method is random sampling.
Maltesh,
Yes, sir.
am I?
Yes, sir.
Maltesh, how long will we take? Because it's 7:30.
Yes, sir. Yes, sir. Sorry for exceeding time. Another 5 minutes, I will move towards.
Okay, because it's already 7:30. So usually we close much earlier and then take questions. 7:30.
Okay. Sorry that I had 3 different groups and I extended.
And the other thing is, there is a question about, sir, adolescents are included in HSS. That's a question. So if you can take that also.
Yeah, I'll touch upon here only. Regarding adolescent, only in ANC, if they are above 15 to 17 years, if they give assent and their parent or legally authorized representative give consent, we include in HIV Sentinel Surveillance. Whereas in other group, any of the groups like prison or HRG, we are not including. They have to be 18 and above. Hope this clarifies that question. So I will move further, sir. I will rush through the slides and conclude in a while. Testing strategy is linked anonymous, which we already studied as for the ANC. But interestingly, the major difference is here DBS cards are done, that is dried blood spot. So instead of having that serum, which requires tremendous resource utilization, here the blood is collected on the filter paper, where the blood is dried, which is almost made innocuous. That becomes non-infectious. That is put in a Ziploc bag and transferred to the designated labs. This saves lots of logistics, because these settings are very different. It is not the ANC OPD sitting in a hospital. These are the TI sites, which may be very far, and some may be near within the houses as well. The blood is collected in somebody's house, so that they cannot have a centrifuge machine over there. So this is a huge challenge which is overcome by technique called as sending the dry blood spots. Even those who have familiar with early infant testing of HIV will be aware of this. So testing protocol is 2 tests for it's same, it's not different from other. The 3 people site in charge is the TI manager, counselor, LT. The case definition for every high risk group, he or she has to fulfill the case definition. Age should be 18 years or more. This clarifies. Except for ANC, rest of the people has to be beyond 18 for HSS. Okay, exclude already approached ones and they have refused, don't include them. So I'll just move with the definition. FSW is 18 years above woman who has engaged in a consensual sex. The period is important in the last 6 months. Men having sex with men, it is 1 month. Within 1 month, they should be men who had engaged in anal or oral sex with a male partner. IDU is 18 years or more, men or women. They should be having taken this addictive substance for recreational or non-medical reason. Okay, if it is medical reason, we are excluding. If it is a non-medical or recreational purpose, at least once in last 3 months, we are including. Hijras or transgenders who doesn't conform to the common notions of male female gender. They identify themselves which doesn't fit into this unambiguous gender role which we belong to. They are called as hijras or transgender. The last two, 18-year-old single male migrant is they should be living away from the family and they should visit their hometown at least once in a year. Long distance trucker, remember 800 kilometer one way between the source and destination. Usually they cross the states and sometimes within the state also. Just HRG methodology at a glance, 250. This is a major difference. There it was 400. In HRG it is 250. 3 months is same, biennial same. For high risk groups, 4 population, FSW, MSM, IDU, and transgenders, random sampling. For British population, that is single male migrant and long distance trucker, consecutive sampling. So this we have discussed. Dry blood spot I have already explained. I just skip this because this is very much needed for the site people. For you, I think it should not matter much, but you should know the process, that's all. For random sampling, once you have a random number, peer educator wise, you call them to the place. If they agree, get the consent, fill in the HSS register, collect the behavioral survey in the form of data form, biological sample in the form of dry blood spot. If they refuse, note the reason and move on. If it is a consecutive site, in the order which they come, you obtain a consent and collect. If no consent, note it and move further. This I will skip it. It's not much needed. This is a HSS register maintained for HRG group. So I'll just skip. I'll just go with so this is just 3 minutes. I'll just run through the slides, which gives you an idea how HIV Sentinel surveillance has actually helped in knowing the data. If you observe, India lies at 1.85% prevalence rate, whereas I'll just hide this. Okay. Oh, sorry. Has my sharing stopped, sir? I'm sorry for that. Hope my sharing has stopped. I'll quickly share it.
1 minute. What
Okay.
happened?
Is it visible, sir?
It's
Not
coming
yet,
up. It's
sir.
coming.
Yes,
It's
sir, now
come.
visible.
It's come.
Okay, yeah, this is quite very interesting. I'll just close in 3 minutes, but I wanted to show you how this long exercise or resource intensive HIV Sentinel surveillance can come up with so much of data. This is one data which is quite interesting. You will understand it. Okay, see the states on the right side. Are you seeing Meghalaya with 10.92% of prevalence rate? Here we should actually check even annual new infection rate, how much it is happening. The states like Punjab, Karnataka, Tripura, Rajasthan, Maharashtra, Nagaland, Chhattisgarh. So FSW has a very high rate over here. So imagine a bridge population coming to these states, soliciting a female sexual worker, going back to their state, and now just you can link how the if you remember that Tim Brown's model, epidemiological model for HIV Sentinel. So how the HIV can transmit. Okay. So this is men having sex with men. See the numbers here, right from 3.61 touching to 12.8. All these states, Assam, Chhattisgarh, Maharashtra, West Bengal till Mizoram, we have very high prevalence among MSMs. So IDUs, again the states including Delhi. Okay, so they have very high prevalence. Can you read this figure at the last bar? 32.08%. So among those who have this IDU, they have a behavior wise, sharing the needle is one of the commonest mode of transmission. That's why they have high. The one good thing is they know their status. They have to be put on treatment, and virologically it should be suppressed. So moving towards last, that is transgenders. It's almost many states have beyond 4, touching to 9.15. So this population behavioral risk factors are quite different from other people, but they come into contact with other high risk group as well as general population. So if the service needs of these people are not addressed, we tend to have higher prevalence rate. Moving further, long distance trucker also. This is what I was telling you. So they come to the various states, go back and transmit the infection. Similar with single male migrants. So the last part is, this should be quite interesting to the youngsters. See, as we adapt to the modern methods, even the high-risk group population has adapted to soliciting clients. Earlier, it was most of them site-based. Now they have shifted to internet-based, out of which I think Facebook and WhatsApp is the predominant social media through which they solicit the clients. So our interventions has to tailor-made, see that they say, for example, avoiding soliciting is a different entity, whereas if they solicit also, they should ensure that they follow safe sexual practices. That is more priority. For example, WhatsApp and Facebook and Grindr are the prominent portals used by MSM. And if you take with the transgenders, almost all are nearly touching upon 40 to 50%. They use multiple portals through which we have to raise our intervention. Lastly, this is my last but one slide, except for thank you. So this is a data management tool indigenously developed by ICMR NIE, used across the country. Previously, it was SIMS, that is Strategic Information Management System. Since I worked over a decade, I used to enter in SIMS as well previously. Now I enter in IESC. This gives a real-time update. Even people sitting at Delhi can know what's happening at any of the site. So for postgraduates, I would tell you, at least read the executive summary of this Sankalak 6th edition, which has been released in 2024. That gives you a good overview of what's happening in our country. I think for your exams also, it would be very easy because I have taken more than 1.5 hours. You can cut it short, at least know what's happening, like a peak overview of what's happening within the country, including this. That's why I have put up this slide. So thank you everyone for patient listening. And Animesh sir, I really apologize for exceeding the time given to me. If still I have time and any questions, I am here to answer, sir. Over to you, sir.
Thank you, Maltesh. It's been very comprehensive, and I believe that it's been useful. I'm not sure if there are questions because I'd asked. And since it's a bit late, I think if it's okay, we will close.
Yes, sir, sure.
And thank you very much. Just to remind you, this is IAPSM Karnataka chapters program, and we started this quite some time back. Today, on behalf of the association, since we didn't have the president and the secretary join, so I took up the onus on myself, being the vice president. So I doubled my duty as vice president as well as the moderator for the session. So thank you, Maltesh. And I again thank Clarnet, our partner, knowledge partner, for this support. Thank you. So we'll close, and this will be uploaded on YouTube, our IAPSM Karnataka YouTube channel, and you will be able to access it as well. This will be uploaded after 2-3 days. Thank you.
Thank you, sir. Thanks to all the participants as well for patient listening, and office bearers of IAPSM Karnataka chapter for giving me a wonderful opportunity, because I used to work, but it's an opportunity to
share your experience,
share with the participants who may actually in future take up at various places. Okay. Thank
Over
you,
to you, Rupsa. Rupsa, over to you. You can
Thank
close.
you so much, sir. Thank you so much, sir. Thank you, everyone, for giving us the opportunity to host this session. So with this, I would like to conclude today's session over here and looking forward to host you again. Thank you so much, everyone.
Thank you. Bye.